Hello and welcome to today's webinar series. Myself Shanti here, and today's topic for discussion is all about Parkinson's disease. And for this discussion, now I welcome our expertise and speakers. As expertise, I like to welcome Dr. Rukmini Mridula Garu, who is our senior consultant neurologist, clinical director from High-Tech City Yashoda Hospital. She is clinical director for Parkinson disease movement disorder from Yashoda unit. I welcome you, ma'am.
Thank you, and
Yes, and
for making me a part of this. And Parkinson's disease is a common disease, and I think this is very important for everybody to know.
yes. Thank you, ma'am. And we are privileged and honored to be associated with you for this learning discussion. And I welcome also, Mr. Chinni, who is our principal from Dave's College of Nursing, Kushaigoda. I welcome you, Chinni. And I also like to welcome Miss Risha, who is a nursing officer from TX Hospital, Kachigoda. Yes. And let us see what we have in the rest of the discussion. Yes, over to you, Chinni. Turn by
Yep.
turn, we will just discuss and learn from Dr. Rukmani Garu. Yes. Over to you,
Good
Chinni.
afternoon, one and all the panel members. Thanks to having me in this webinar today. And audience also eagerly waiting for that actually. This is a very relevant topic, madam. And coming to the first slide, what we have given that what is a Parkinson disease? Disease is a degenerative disease of the brain nervous system that causes tremors, particularly in elderly. And parallelly, if they have given that pathophysiology of the Parkinson disease. Ma'am, coming to the point, like exactly they have given the 2 points, madam. We wish to understand that Parkinson disease is degenerative disease. What exactly the mean, man? Yeah,
So,
please.
to be a little more clearer, Parkinson's disease actually is something called as a proteinopathy. So, an abnormality of the brain cells, the neurons, to get rid of a protein called as alpha-synuclein. So what happens is this alpha-synuclein accumulates in the neurons and the neurons die. So they slowly die. So that's why it's called as a degenerative disease. Now brain cells cannot regenerate. So when whatever brain cells that you have from childhood, that is only going to be there till you're adult. So if they die, that part of the brain gets shrunk. So this is a degenerative disease where the parts of the brain, actually neuron, keeps on dying.
Yes.
It
Okay.
causes tremors, which is true. But I think we can go back and we can discuss it later.
Yes, yes. And also, ma'am, does it also affects our cognitive function as well, ma'am?
So Parkinson's disease is predominantly a motor syndrome. So initial period, it actually affects only the motor component. So they have tremor or slowness or akinesia.
Yes.
But the thing is that as the disease progresses on a long-term basis, after 10 years or 15 years, it can affect the cognition to some extent.
Yes. 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 Over to you, Sarisha, and we'll just go on for the discussion. Yes. Sarisha.
Hi, this is Richa. So we know that this is all a nervous system disorder and it is particularly found in the elderly. But we want to know what actually happens in the Parkinson's and how does it affect our body? The shaking of hands and unable to hold the glass or even to hold a pen or even the stiffness. Can we actually know what happens, ma'am? What happens in Parkinson's disease? Over to you.
So thank you. So the thing that happens is that you have a tremor, but Parkinson's disease tremor typically is a rest tremor. Means the tremor starts when the person is actually at rest. So initial period, they may actually be able to hold the glass and they may be able to hold it late, but later on it can change into what is called as an action tremor. So typically Parkinson's disease is a rest tremor, but they also have slowness in their movements. So if they have a glass of water, they can take the water, but to bring it to the mouth, it becomes very slow. Or when they mix food or it becomes very slow. So slowness in all activities, just walking, holding object, mixing food, anything with their hands and their feet. Even when they're walking, they may be walking with small steps, their hands will not move. So that is the next symptom. The other symptom that you have is stiffness, which is called as rigidity. So the whole body can become stiff. So they can bend down, they can have a posture change. Handwriting can change, it can become smaller. Voice can also become lower. Every amplitude of all movement, speech, everything comes down. So that is what happens in Parkinson's disease.
Yes. Yes. So yes, Chinmi.
Yeah, ma'am. Coming to the third slide, madam, regarding the parameters in recent days, they have given the numerical data, madam. Coming to the Parkinson is the second most prevalent neurodegenerative illness. It is characterized by the low dopamine levels because the substantia nigra loses dopaminergic neurons. Among neurological diseases, PD has shown the fastest increase in frequency and impairment in recent years, making it one of the primary causes of the disability globally. And coming to the global burden of the Parkinson diseases from 1990 to 2021, that recent data that it been shown as very clear, like recently it's getting very numerically it is increases, madam. What exactly the opinion on that? Like, is it really increasing the parameters in nowadays, ma'am? What's your opinion on that, ma'am? Over to you.
So again, Parkinson's disease actually is the disease of the elderly. So the prevalence of the Parkinson disease increases as the age increases. So there are two reasons why the prevalence of Parkinson's is increasing. One is our lifespan is increasing. So we have a lot of population who are older. Now, whether incidence is increasing, I mean, in the younger population, is it still debatable issue, because even though we are seeing it, we are not sure that whether it is increasing so much. Prevalence is somewhere around 20 to 40 people per 100, per 100,000, 10,000 population. That is around 2 per 1,000. Roughly 2 per 1,000 is the prevalence. But as it goes older, like if you have more than 60, it can come down to almost 1 to 2 per 100. So that is what is happening. In Indian population, we think that it affects it younger. So we may actually be seeing it a little earlier than the rest of the world.
Yes. So yes, ma'am, that is a very interesting numerical fact you have provided to us. And now, I wish to understand: does Parkinson's affect only aging, as you said? It is it affects the aging population, and who is at risk for this PD? Because when I was citing little and browsing the articles, even I found this young onset of Parkinson disease also is been seen, and maybe you're the expertise, and what is your intake on the same? And yes, over to you.
So the thing that is happening uh, is that young onset Parkinson disease can happen in around 10 to 15% of the people. So this is young onset means less than. So there are two different definitions. So actually, the definition also is not very clear. Some people have taken it 50, some people have taken it 40. So what we follow is we all follow less than 40 years. So because there is we are a part of a group called as Parkinson's Research Alliance of India. So we have been looking at the young onset PD, and we've had a publication, couple of publications which have come up. So young onset PD can be genetically mediated. So when they are less than 40, so they tend to have genes which are causing it. Some, like, there are specific. So Parkinson's disease in this young onset is something called as monogenic genes, where a single gene can cause the disease. So you can have say Parkin mutation, which is very common in India because of consanguinity, autosomal recessive. So they can cause Parkin mutation can cause Parkinson's disease, as well as PINK1 and DJ1 can cause.
Yes. Yeah, as you rightly said, autosomal recessive and consanguinity, yes, two most prevalent factor, yes. Yes, over to you, Surisha. I think most of these symptoms have been discussed by madam, but then again, you can have your insight, yes.
That was actually something new which I got to know, that even younger children, like about the young age, are also being affected by Parkinson's disease. But I want to know, what other symptoms do we have, like other than the tremors and loss of balance and speech and having difficulty in their handwriting? What other symptoms do we find in PD that will it actually differ from every individual, or would it be the same for every age group likewise? I would like for you to share some insight on this, ma'am. Over to you.
Yeah, so actually, we don't look at a lot of changes between the young and the older age group, but tremor is predominantly seen more in the younger people. Asymmetry is more common in the younger people. So when we have these symptoms, we divide them into motor and non-motor symptoms. So the motor symptoms are what are affecting the motoric aspect. So the motor symptoms can be diagnosed as TRAP. We used to have a lot of mnemonic for it, like tremor, rigidity, akinesia, and postural instability, balance issues. Non-motors affects a lot of domains. So most common is loss of smell, which is very commonly seen. Constipation, which is also quite commonly seen. If you have a and sleep disturbances. So sleep
Yes.
disturbances, we have something called as dream enactment or RBD. So if you think that you have a combination of the sleep RBD, the loss of smell and constipation, they can precede the Parkinson disease and they can predict the appearance of Parkinson disease in almost 95%. You have to have the combination of all the three. Otherwise, you don't. So constipation is very common. So it is not
Yeah, it
necessary that
is.
all
Yeah.
constipation patients should have Parkinson's disease.
Yes,
But if you have a
yes.
combination of RBD, constipation, and smell disturbance, then you can have
Anosmia.
a problem
Yes.
with anosmia is more likely to be it. Younger
Yes.
people don't have so much of loss of balance. Older people tend to have more balance loss and they have more speech abnormalities. They have difficulty in swallowing compared to the younger people.
And I think it is very unlikely that a person maybe younger age and the one who is chronically constipated, and they may not just
Yes,
seek your opinion because constipation means they'll just go to
correct.
gastro. Yes, yes, very thoughtful awareness you have provided. Yes, over to you, Chinni. And I think
Yeah.
this is my yeah, this is by you. Yes, Chinni.
Coming to the next slide, madam. I think I'm a bit curious about what the risk factors and causes we have in the Parkinson disease, madam. Here, four things we have to do. I want to know, madam. In first point, they have mentioned as advancing the age. Generally, people developing the disease around 60 years or more. That first point. And second, men. Why only, especially in men, compared to the women? That is the second point, madam. And coming to the third point, it's
Yes.
like in first slide, you have missed the point like pathophysiology about that dopamine system we have. Like if it's getting
Mhm.
low, automatically it will affect your
Correct.
brain. That functioning also. That we have missed, madam.
Yeah.
I think again we have triggered that point here in low
Yeah.
dopamine levels and why all these symptoms really worsen to the risk factors, man. That's we have to consider. Why? What's the reason? Over to you, ma'am.
Thank you. The question, risk factors, we still don't have so much of clear-cut risk factor, as you said. But I think, I mean, the ability of, because it's a proteinopathy, all the proteinopathies actually, the protein accumulation worsens as the age progresses because the capacity comes down. So I think for Alzheimer's dementia or for Parkinson's disease, these are all proteinopathies where the protein gets accumulated. Now, that being said, that's why the age is there. But younger people also have it. Younger people actually, because they have it, because they have a gene abnormality which is required for either breaking down the protein or which causes an increased production of the protein. So that's why we get it in the young onset PD. So a lot of our science is built up around the young onset PD. That we know why it is being happening because of those young onset PD patients. Men are more prone. Yes, it's almost 3:1 ratio for, I mean, Parkinson's disease. Again, why it is like that, we don't know.
Okay.
We think that estrogen is protective,
Okay.
not the other way around.
Yes.
So there are a lot of studies which have been trying to, get the protective mechanism of estrogen and use it for therapy. Unfortunately, none of them have proven such a benefit. But
Yes.
definitely men are more prone. And this actually, as the estrogen level drops in the older age, women also become more affected with Parkinson's disease.
Yes.
We are right about low dopamine level. The nerve which is getting damaged is actually what we call as a substantia nigra pars compacta. These
Yes.
are dopaminergic neurons. They produce dopamine. So because the nerve neurons are getting damaged, the reduction in dopamine, and that's what causes the symptoms. So that is the
Yes.
pathophysiology part of it.
So, ma'am, what I assume is like, so one should have the normal level of dopamine for, I think, yes. And for this, I think, yeah, I think, yes. Over to you for your insight. Like, I was just going through what
So
should be
the
the level.
dopamine is
Yeah.
produced. The level of dopamine actually doesn't really change in the blood or
Yes.
in the brain overall,
Yeah.
because dopamine is
Yes.
actually produced at a lot of places in the brain.
Yes.
But
Yes.
in Parkinson's disease, it is a typical and a specific area where you have substantia nigra pars compacta only. In that area, the dopaminergic neuron is getting damaged. So
It's
that is why
yes.
you give levodopa to counteract that drop in that particular area. But sometimes the medication can cause side effects because the dopamine can spread to the other areas of the brain also
Yes. Yes.
when we give
So,
medicine.
yes. And how one should identify the red flags? I mean, it may, appears
Yes.
all of the
So
sudden. Yes.
yes.
as
So
you said.
definitely loss of smell, if it is not related to any infection. So
Yeah.
like a lot of people who had COVID had loss of smell and they did not recover. So it doesn't mean that they're going to develop Parkinson's disease. But if you
Exactly.
have a combination of loss of smell with constipation and sleep dream enactment, not not having dreams, but having dream enactment in the sense that in the dream, if they have to move something, they actually move their hand. So you have to ask their bed partner, like you have to ask their wife or the children, if they're sleeping next to them and they hit them or they speak out in the dream. So that is dream enactment. So a combination of these three is definitely a red flag. And obviously slowness, if the person is looking, a lot of patients come with the complaint that they become dull, their facial expressions have come down because they're not blinking their eyes so much. The face smile is not so much.
Yes.
When they're walking, their hands don't swing so much. So these are all features of slowness in activities.
Slowness. Yes.
And tremor, resting tremor, whenever you have a tremor on rest. So especially if you're walking and the person develops a tremor, or when you're seated, the person can develop a tremor. What you should also realize is the stiffness can also, it is so it may start in one hand and one before the other hand. Normally, older people, it develops more in the upper limb, but it develop in the leg. So you should see whether the stiffness is developing in or in the hand. Especially the younger, you should ask them in the leg. Sometimes people go to orthopedic surgeons because they think that they have stiffness of the shoulder, they can't move their shoulder
Yes.
periarthritis. So they think it's a joint
Yes.
problem. That
Yeah.
it could be Parkinson's disease.
Yes.
Yeah, so these are
When
all
we
the
yeah.
features that you can see.
Yeah, so these are kind of like I could a little anticipate a mixed of ENT referrals, a mixed of rheumatic, mixed of ortho, as you said, and gastro. But very
Yes.
interestingly, yes, so this sign symptoms differs. Yes, Srisha, you would like to just ask this slide for ma'am's view. Yeah.
Like, although we actually know that basically Parkinson's disease are like diagnosed with the medical history of the patient or getting to know by the physical examination or a neurological exam, or basically even CT or MRI. But this dopamine transporter is quite something new, which is shiny for me here. Ma'am, could you please share something about this for us? Over to you.
Yes, ma'am.
So normally we do it through, as you said, with a medical history and a neurological and a physical examination. MRI
Yes.
and CT are normal in most patients. There are some sequences which you have to do very fine scans to actually pick up any abnormality on the MRI. So MRI is usually not a diagnostic feature. We usually we do what is called as a levodopa challenge test. So you just give dopamine in forms of levodopa and see the improvement. So once you see the improvement, that is like the best sign for us to see whether it's Parkinson's disease or not. Now, very early stages, dopamine transporter scans can be abnormal. There are two types of scans which are present. One is a SPECT and one is a PET. So SPECT is where we use something called as TRODAT. We don't have a DAT. DAT is available in the Western world, but we use something similar which is called as a TRODAT, which can also pick up the loss of dopaminergic neurons in the brain. Or we
Correct.
can use something called as an F-DOPA PET, both of which are abnormal during the patients with Parkinson's disease.
Yes. Yes.
So we
Yes.
can, and we usually do this for very early disease, or when you have a difference. Suppose you have a patient who's on medication which can cause Parkinsonism, like antipsychotics. Then you want to differentiate whether they really have PD or not. Then we do the scan, or if they have essential tremor, which is a tremor
Yes.
which happens when they are, holding objects. So that's when these scans come up, and yeah, they are really exciting. You can see
Yes.
the asymmetric change in the, as you said, I mean, because the disease starts asymmetrically, you can actually pick up the asymmetry very nicely on the scans.
Understand, yes. And these are the very interesting advancement which is happening with this specialty. Yes. Further, yes, Sirisha, over to you again. Yeah.
So I was just thinking, although the nurses are aware about the MRI, CT, and like how you have explained that we'll be finding an easy, clear visualization how to differentiate between a PD and a normal scan. This is something which is found a bit attracting to me, the DBS, the deep brain stimulation. Ma'am, I would like to know if it is like a one-time procedure or it is like a repeated procedure. Is it better than using just a medication? Is it mandatory to go with it? I'm quite curious about this, ma'am. Please let us
Yes.
know about
Even
this more.
I think all of us wish to understand because yes, such a great technology is in place. Yes, ma'am.
Yes. So this actually it is this technology, which is a brain pacemaker, is been there for Parkinson's disease for more than 30 years now. And we have been doing it for more than 25 years in India. So one of the centers from, I mean, we have come from NIMS. So my professor, Dr. Rupam Borgohen, and who I was studied under, and I joined back with him. So we have also been doing it from almost 2001. So from 2001, we were in NIMS, and now we are doing it in Yashoda Hospital.
Yes.
I mean, there's a lot of improvement in the technique, but it's an amazing technique. It's like a second miracle for the patient after the levodopa, which has come. So
Yes.
medicine, the problem with the medicine is that, as I told you, in the brain, only a part of the neurons actually require dopamine. The
Yes.
rest of the brain doesn't require it.
Yes.
And all of our medications that we give cannot give a continuous dopaminergic stimulation to the brain. So they fluctuate.
Yes.
And unfortunately, we don't have any medicine which can prevent the fluctuation. So these are two disadvantages. One is that the fluctuation is there, and it is not a non-specific target. So you get side effects of the medicine because dopamine spreads to the rest of the brain. Whereas deep brain stimulation is where you put in an electrode and you're specifically targeting the particular area where you want the stimulation to go on. So we actually use a very high frequency stimulation. It is a modulation. We used to think it was an inhibition, high frequency mediated inhibition, but it's basically a modulation of that area called a subthalamic nucleus. And patients respond extremely well. Most of the patients require it after a stage, like after, say, 4 to 5 years of taking the medication. Initial period, they're really happy with the medicine. Once they start developing side effects, and if they're taking a lot of medication, so if you're taking more than 5 tablets per day, then you should think about going for surgery.
Yes.
Or if you are having 2 hours of off, we call it, or 1 hour of side effects, you should go for it. It
Yes.
is not okay. So the thing is, the electrode placement in the brain is a one-time procedure. So you place the electrode, but it's a pacemaker. So you actually connect it to what we call as a battery or a pulse generator outside. We do it under general anesthesia. Under local anesthesia, initial part of the brain, where actually we do an on-table stimulation. So the patient is awake for the surgery, is under sedation for a short period, but during the surgical procedure, we actually give the current on the operation table, and we see the response on table. We see, oh, there is an improvement. And we are like, okay, fine, we can put the electrode and come out. And the second part of the surgery, where the wire is passed and connected to a battery which is placed under the chest, is done under general anesthesia. So the battery has to be changed because the battery has a life period. So some of the batteries last for 5 years, some of them 15 years, some of them 25 years. That part of only the chest surgery has to be repeated. The brain surgery is once.
And as you rightly said, it is underneath the skin of the chest, ma'am.
Yes.
Yes. Yeah.
Yes.
Like we have a
Nothing is
TPIs.
seen the outside.
Yes.
You don't see anything from outside.
Yes.
It's just like a cardiac pacemaker.
Ah.
Like even cardiac pacemaker is also like that.
Yes. Yes. And these patients can go for MRI and all. Is it a MRI compatible?
It is
Sometimes.
not an MRI. So the MRI compatibility means that we have to switch off the programmer before we
Yes.
take the patient up for MRI, because the
Yes.
electrical current can cause a little heating if you are passing the MRI. If you put the patient under the MRI, so around the electrodes you may have a heating. So you switch off the battery and then you take the patient up, and then you switch it on and then you take the patient. The switching on and switching off is done by a Bluetooth device.
Okay.
So we actually program the system because it's a progressive disease.
Yes.
So it's
Yes.
not one time and then you
Yes.
don't change it. So you have to modulate the current. It is really, really interesting. If you have a chance, you
Yes.
can
Yes.
come and
Yeah.
visit us also.
Yes, yes,
Yes.
we will definitely, yes. And I think patients are also being educated about how this mechanism works, if there is
Yes.
any problem, who to
Yes.
contact, all that. Yes, ma'am. Yes, very interesting. Yes, we will definitely visit and see, your advancement thing. Yes, Chinni, I think, yeah, we have
Yeah.
only, two more slides and then we are ending the session.
Yeah.
Yes.
Before going to the next slide, madam, I just want to know a bit more about the DBS. If anybody have a pacemaker, what about the compatibility if they'll go for the DBS, madam? If suppose anybody have
It's
the
compatible.
pacemakers,
It's
they
still
can go for the
compatible.
DBS.
Yes, they can go
Yes.
for the biggest. You can usually place it on the opposite sides of the chest. Sometimes, if we think that even if the chest is a problem, you can put the pacer in the abdomen also,
Okay.
Yes. Oh,
below the
oh,
abdomen.
okay.
Okay. Thank you, ma'am.
Yeah.
Coming to the next slide, like this is a very common thing, madam. In every point, we are going to end up with the general thing postpartum, like exercises, so diet, these and all, ma'am. And what is
Yes.
a major role about the exercise, madam, in Parkinson's? What's your opinion on that, ma'am?
Exercise is very important for Parkinson's disease. The more that they exercise, the better it is. There is a huge, I mean, we call it as high amplitude exercises are very good because the movements are slow in Parkinson's disease. So large amplitude exercises is very good. There's a very old technique which is called as Lee Silverman technique, which has been done for almost 20 years or so. We can use those exercises, but any kind of aerobic exercises are very good.
Okay. Yeah.
The,
Coming.
Swimming is also very good for Parkinson's disease. So all of them are important.
Definitely.
yes.
Yeah.
Yes.
Next, coming to the 10th, madam, what is the potential complications of the Parkinson disease if not treated? And here, majorly, they have highlighted the 4 points, madam: forgetfulness, emotional disturbances, and problem in the swallowing, disorders of sleep, difficulty in controlling urination.
Yeah, so these are long-standing diseases.
Mm.
Happens is that patients can have motor abnormalities. They can become very slow if you are not able to treat them. Apart from that, if you're having a lot of medication, some of the medication can cause cognitive impairment. So forgetting can cause psychosis, behavioral changes, mood changes. Urinary abnormalities also can become, they can have urgent incontinence, which can become more and more severe. So these are complications that can happen. Drooling is something which drooling, open mouth, if they're not exercising properly, if they're not given enough medication, can be because they can have difficulty in swallowing saliva. Difficulty in swallowing food is a very late complication, but it can happen if they are not on a long standing process. So, all of these complaints actually are kind of reduced when you think about DBS. So, the chances, these all happen very late. I won't say they don't happen at all after DBS, but with DBS, you can actually extend the time period of good, good life by at least 10 to 15 years. So, they can prolong all these complications by 10 to 15 years.
Yes, and can perform activities of daily living. Yes, a great insight you have
Yes,
provided,
they
ma'am.
can.
I think, yes, it was very interesting. And within this 20 minutes of time, we cannot finish the PDMRC insight. Yes. So request all the, viewers to just refer www.yashodahospitals.com for more health updates, academics, and also watch patient testimonials. And as madam said, evidence-based learning. As we see this is what madam was just discussing. There's a team of PTMRC expertise we have in Yashoda High Tech unit, and in case of any doubt, you can just refer our website, and you will have lot of and gain a lot of information as well. Yes, ma'am. I'm very thankful to you for your valuable time. I thank Mr. Chinni and Sirisha as well, and we end the session. Thank you. Keep
Thank you
sharing
all,
this
madam.
view for
Thank
more
you.
awareness. Yes. Thank you, ma'am.
Thank,
Thank
Thank
you.
you, madam. Thank you.
Thank you.
thank you.
Thank you.